Hello everyone, today we'll be studying about the definition of retention and relapse and the causes of relapse. So let's begin. Retention has been defined by the Moyers as maintaining newly positioned teeth in position long enough to aid in stabilizing their correction. Relapse has been defined as loss of any correction achieved by the orthodontic treatment. Now, the next is the causes of the relapse. We have the mnemonics PR3 and BFM. So for P, we have periodontal ligament traction. Whenever teeth are moved orthodontically, the periodontal principal fibers and the gingival fibers that encircle the teeth are stretched. These stretched fibers can contract and are thus the potent cause for the relapse. The studies have shown that the principal fibers reorganize in about 4 weeks' time. The supraalveolar gingival fibers, on the other hand, take about 40 weeks to rearrange around the new position and thus predispose to relapse. After comprehensive orthodontic treatment, the teeth require 4 to 5 months of full retention so as to allow the reorganization of the periodontal ligament fibers. After this period, the retention should be continued on a reduced basis by a further of 7 to 8 months so as to allow the more sluggish gingival fiber to readapt to the new tooth position. R for relapse due to the growth related changes. Patient with the skeletal problem associated with the class 2, class 3 open bite or the deep bite malocclusion may exhibit the relapse due to continuation of abnormal growth after the orthodontic therapy. The studies have shown that the original growth pattern resurfaces or dominates if the orthodontic treatment is completed prior to the completion of the growth. Hence, prolonged retention is indicated until active growth is completed. Now, the next R3, the role of third molars. The third molars erupt very late in the development of the dentition. They erupt in more cases between the age of 18 to 21 years. By this time, most patients would have completed their orthodontic treatment. The pressure exerted by the erupting third molars is believed to cause the late anterior crowding, which is predisposing to relapse. Now next R is role of occlusion. Good intercuspation of the upper and the lower teeth is an important factor in maintaining the stability of treated cases. The centric relation and the centric occlusion should coincide, or the slide from the centric should be not more than 1.5 to 2 mm in order to have the greater stability of the treatment results. The presence of certain occlusal mannerism such as clenching, grinding, nail biting, lip biting, etc. are the important causes of relapse. Now we have B for bone adaptation. The teeth that has been moved recently are surrounded by lightly calcified osteoid bone. Thus, the teeth are not adequately stabilized and have the tendency to move to their original position. F for failure to eliminate the original cause. The cause of malocclusion should be determined at all time of the diagnosis, and adequate treatment steps should be planned to eliminate the same or reduce its severity. The failure to remove the etiology can result in relapse. Next is M for muscular forces. The teeth are encapsulated in all directions by the blanket of the muscles. The muscle imbalance at the end of the orthodontic therapy can result in reappearance of the malocclusion. The orthodontist should aim at harmonizing the muscle at the conclusion of the orthodontic treatment so as to increase the stability of the treatment results achieved. So this is